I'm Daniele Roberto Giacobbe. I'm Associate Professor of Infectious Diseases at the University of Genoa, in Genoa, Italy. And also I am an MD, Infectious Disease Specialist, and at the Hospital San Martino in Genoa. My expertise is about the treatment and the diagnosis of invasive bacterial and fungal infections, especially in the ICU, which is also one of my main fields of research. I'm also interested in the use of artificial intelligence and machine learning for the diagnosis and treatment of invasive bacterial diseases and fungal diseases. Molecular testing for respiratory infection, I think it's a novel addition to especially the clinical reasoning on the clinician, because usually there are only a few dynamic phases in which the clinician decided whether to treat or not to treat and whether to change the therapy for respiratory infection. At the onset of the infection, so when empirical therapy started, and then when culture, especially for bacterial or other molecular tests, classical molecular tests for viruses become positive. So there are only two phases mainly in which the decision about whether to start therapy, whether to de-escalate, whether to escalate therapy are made. With multiplex rapid molecular test, we have the possibility of increase the number of dynamic phases in which a clinician have to think about what to do with the therapy of the patient, whether to start it, whether to change it, or whether to discontinue it. And now we have the onset of the infection, so the initial empirical therapy, then the result of the multiplex test, and then the result of the classical culture and other tests. So you are increasing the number of occasions on which you can think and revise your therapy based on the information coming for the test on the patient. So you are going towards precision medicine, I think, with this approach. We presented some preliminary results of an observational study, so conducted in real practice, in real-world practice, about the use of a multiplex panel for ventilator-associated bacterial pneumonia compared to classical algorithm in a patient in which the etiological diagnosis is made only by culture, compared with a patient in which diagnosis is made by combining culture with rapid test. And I think that the very interesting thing of preliminary results is to see and to study how decisions of a clinician at different time during the course of the disease and assessment of the patient is changing based on the additional information that clinicians have in novel and different points because of the availability of the rapid test. I think that a key aspect is to stress that the assessment of the patient for decision is dynamic, and with multiplex test, you now have novel points in which your clinical reasoning have to evolve, to decide and to take in account novel reasons that are available. From the perspective of a researcher, it will be important in the future to see the long-time effect of decision based on the availability of this test, especially in the realm of antibiotic stewardship.